Okay. Well, hi everyone. I'm Karina, they, them.
I go by Z. I do see my Zoom name says Sarah, but I like to go by Z and she or they pronouns.
Awesome. And I'm glad that we're able to meet this week. So for discussion two, we're kind of doing a lot of different questions. Should we go one by one or how do you feel?
I feel good with one by one. You want me to read the first one?
Sure.
Okay. What do you think about the guidelines of insurance companies, like the need for a diagnosis, usually from the DSM-5, and the implications to confidentiality? And what do you consider right or wrong when maximizing the client's insurance coverage beyond what is legal?
Well, yeah. It was interesting reading some of the like articles and readings this week in general about how like fraud can so easily be done um through like diagnosis and some of it comes from like not a harmful place. It's like clinicians might be trying to get like a treatment plan for their client, so they might diagnose them with something even if it means that won't actually they don't actually have that diagnosis, or they might
Mhm.
underdiagnose them in order for like that person to be able to get, I don't know, resources in another way. So yeah, I guess that's where the ethical part comes in. It's also, I was actually talking about this a bit in my practicum group class this morning, and how, like, we're also working with the systems, especially for oppressed people that kind of like um, have a lot of, like, I guess, roadblocks in place so they aren't able to get resources. So it's kind of like, yeah, clinician might be trying their best to like work within the system in order to like get someone who's super marginalized something that they're not able to get to.
Absolutely. Um, I think, yeah, the need for a diagnosis in insurance can be really unfortunate. And I'm also thinking like my experiences in community mental health, like
Mm.
Medi-Cal regulations often require that a diagnosis be given extremely fast. And
Mm.
so I've worked with a lot of clients who have just cycled through like involuntary hospitalizations where they have so many different diagnoses that are all very unsupported. Like there's no possible way they could have all the different diagnoses in their chart. Um, Something I'm negotiating that's interesting is most of my career, I've worked as a substance use disorder counselor in community mental health kind of settings. And for my practicum, I'm at a um, co-occurring disorders facility, but substance use primary that's pretty expensive. Like it is catering to a population where a lot of people actually choose to pay out of pocket rather than use their insurance just to keep that substance use diagnosis off their medical record.
Yeah.
And that is an aspect of privilege I've never thought about before, that if you can afford not to use insurance, you can kind of receive treatment without these diagnoses being like tagged onto your record forever. Um,
I didn't know that was even a possibility. So wow.
right?
Yeah,
Yeah.
that's crazy to hear.
Hmm.
Wow.
And one ethical dilemma I feel challenged by often is the diagnosis of PTSD, which is so highly specific in order to meet criteria, because I'm constantly working with clients who have really significant trauma. It very significantly impacts their life, but they don't necessarily meet diagnostic criteria for PTSD. So
Mhm.
I am conservative about that diagnosis. Like that's not something I would ever want to overdiagnose, but sometimes it can be challenging to figure out an ethical way to navigate it. Like, are we treating anxiety, even if I really think that it's trauma more so than like a generalized anxiety disorder, but that's what you can justify. It's challenging to navigate.
Yeah, that brings up a good point of making sure. like talking about the shortfalls of like diagnosing and how you have to super make sure that everything lines up with the actual diagnosis, or else, yeah, you have that kind of possibility of over diagnosing for something that, you know, PTSD versus like generalized anxieties. Like there's definitely differences there. Um, yeah, I can't imagine, since I haven't done any diagnosing and for my practicum, I'm at a school, so I won't be doing that.
Mm,
I'm always just like, huh, I wonder what that's going to look like for me in the future. Actually, in my psychopathology class this semester too. So I'm just like, there's so many, yeah, so many factors in that that I'm very like, huh. It's super easy to kind of fall into the, I lost my train of thought. It's more of like, I guess we're doing a lot of just in case something happens, let's do this thing as like a guideline. So we're not like, we're trying to minimize harm as much as possible. But yeah, um, it's a very tricky situation in general, I think.
mhm. Yeah, it's almost a relief working because I work substance use primary because all the clients by default have a substance use disorder. So
Mm-hmm.
we can get insurance authorization there.
Mm-hmm.
That's still not easy. That's still a whole like circus, but their ongoing treatment isn't like contingent on the mental health diagnoses. Like we're allowed to treat mental health diagnoses, but the coverage isn't like hooked onto that.
Yeah, that's great that there's like, yeah, the default, so that if there's any like comorbid type of diagnosis on top of it, they won't lose like coverage for the other part. Yeah. Should we move on to number two?
Yeah, I'm ready.
Okay, so is telehealth a viable option for clinical work? Why, yes or no? Do you feel competent in practicing telehealth? If not yet, what do you need to be competent?
I can start out that one. That feels good.
Mhm.
Um, I think it's definitely viable. I've done a fair amount of telehealth
Mhm.
work and in my current practical role, and also a lot of telehealth group and individual counseling throughout COVID and afterwards. And yeah, I could speak to the impact of it. And I've also had a lot of clients speak to the impact of it. I think one of the biggest benefits for me of telehealth is the accessibility factor.
Mhm.
So for clients who have mobility challenges or transportation challenges, they might be able to consistently engage where they otherwise might not be able to at all. So I think that's one of the big benefits. Um, I do feel competent in general, but was also surprised by some of the things in the high tech checklist that I wasn't aware of. So there's definitely like the like checking address every session. Those were things I weren't aware of.
Yeah, my practicum is all in person. So I could only really speak to being like a client in telehealth. And I really like telehealth, especially going from, in lockdown, being able to have that as an option for therapy was super helpful for me. I am also super aware of the risks of like cyber security and how like there are probably things about it that aren't 100% like as far as like encryption, um, things that I'm very much just like, it's fine. I mean, I guess for me, I'm like, I'm not like high risk for anything in particular being out in the world about like me in sessions, or at least I
Mhm.
feel like I'm fine if something were to happen. But um, yeah, I do wonder when I have like classmates who are in like 100% telehealth practicum. So I actually wanted to talk to them about that and be like, huh, I wonder how you feel about doing that and like what your training looks like compared to like me who's doing something in person.
Mhm.
Because I'm sure there's a lot that goes into it and a lot that's still being like brought up because it's so new.
Mhm. Mhm. Yeah, I think telehealth is not my personal preference, like on the as a therapist. It's something I'm happy to offer, but interestingly, one of the things I think about as being kind of the bigger costs of telehealth is like my body is not present to the client. And the impact you can have in helping to someone self-regulate just by your posture being at ease, your breath being at ease, and kind of embodying that like grounded softness,
Mhm.
it almost feels like a huge part of my toolkit is um, not enabled in telehealth setting. And same way, like I don't receive that field like from the client's body. I get like here up, but um, yeah, definitely effective, but there's costs and benefits.
Yeah, I definitely wonder how it'll look like for me in the future because yeah, I'm doing like expressive arts therapy. And for me, I have done like, faux sessions with classmates where we do art over Zoom,
Mhm.
but it's just like not the same as doing art in person with
Mhm.
somebody. Um, and yeah, similar thing where I just like being in a room with someone. I do miss like I have a current therapist over telehealth and I do miss having someone in person. So I think maybe in the future I might try to push for something in person just because I do miss that kind of like connection that you get just from seeing someone in front of you.
Yeah, for me, it helps prevent burnout. I know, like during COVID, I was like the most burnout I've ever been, just always in front of a screen.
Yeah, yeah, that's also a good point. Very good point. Um,
Move to number 3.
yep.
What about the burden of keeping records and practices that are HIPAA and high-tech compliant? How to deal with it?
Since I feel like you have a little bit more, or a lot more experience than me at the moment, I'd love to hear like your perspective about that.
To be honest, like I'm not a huge techie, and these are the sort of things where I like to outsource it, like not outsource, but really just consult people who know better than
Yeah.
I do.
Hmm.
Um, and there are people whose whole they're like telehealth consultants that help programs make these transitions and help therapists know what to do. So I think for me, that is my approach is just to acknowledge my humility and like this is not my area of expertise. Like I do need someone with more solid ground. Um, yeah, what else? Um, I've actually had some anxiety about this at my newest agency because their electronic health record is browser based, which feels super weird to me because I'm used to electronic health records. It's like some sort of portal that you have to log into and like it won't save your username or password and like all these different barriers. But
Wow.
theirs is just like you log in through a browser window and that feels like wrong to me. But I did do some so that's also part of how I dealt with it is I did do some individual research about this EHR and it is legit, I guess. But yeah, that just seems strange to me because that means you could log into it technically from any device. So there's a lot more room for human error. So I do see colleagues like using their phones and personal laptops, and that's a no for me. Like I would only log into that through my work computer, which has those protection things. Like it could be remotely wiped if it gets stolen or like all
Mhm.
these other things.
Yeah, that's a great point of being able to have like the boundary of like, oh, I should be, because these are really like sensitive files. So like you're being given like the trust of like a client that you're able to like keep that as much as you can like secure. So I do like the idea of at least like having something like a work laptop where it's like separate because so many things could happen on personal devices. Um,
Hmm.
I actually thought about so I do have to do case notes for my practicum with Oakland Unified School District, but we just use our Google Drive for it. So it's kind of a thing where I'm like, huh, I think I would like more like training on how to keep this super secure. I feel like they're actually this past couple weeks of me just getting used to my site being like, oh, there are a lot of things that I learned about in my ethics class over the summer and currently where I'm like, oh, some things are not ethical here. And I
Hmm.
don't know how to be like, hey, how do I do? So I might just have to do things on my own and like just for, trying to kind of uphold this kind of standard, especially post practicum and then wherever I go in the future. I want to make sure like there's something in place, because I'm not being given that at the moment.
Yeah, I hear that. The Google Drive it's a norm at my site as well, and it makes me nervous. I'm like, really? Google
Yeah.
Drive, shouldn't this be like in a document, like in an encrypted network? Like, because Google is not the most secure, especially if you're able to log into the same account on personal devices. It just makes me, but I relate to that. Like the agency might not be ethical, and I might not have the power to whistleblow that or make institutional change, but I can do things like limit myself to my work laptop, or for me, like keep things in Word docs instead of drives. But just those small individual things.
Yeah, I guess that just kind of speaks to the systemic problem with it versus like the ethics of the clinician themselves.
Mhm. It's funny. I
Um,
think these issues are part of what keeps Microsoft Office like in business, because that's part of what the value is like a
mhm.
HIPAA compliant shared drive. But that would mean the agency has to pay for that level of Microsoft, and not everyone does. They're just like, use a Google Drive, it's fine.
Yeah, that's a good point. Yeah, for something like the school district, when I was going into it, I was like, I know that it's extremely underfunded. So trying to be like, okay, they're using the resources they have for like a public school system. Um, yeah, just kind of more apparent what's missing. Um, well, anything else we should add? Any last thoughts?
That feels pretty solid. I feel good ending the recording here.
Awesome. Perfect. All right. Thank you.
Thank you.